Okay, so in terms of what's going to be happening this afternoon, so in order to help your online conference experience, this is a little bit of housekeeping. Some of you are used to Zoom and online, and some of you maybe not so much so. I'm going to strongly recommend you keep your volume turned up to your own comfort. If it helps, wearing headphones, plugging them in can improve this. So do please make sure you've got some to hand. Or if you have trouble with your volume, do consider headphones. We're going to use the group chat today. The group chat can be found in the Zoom controls, which will either be at the bottom of your screen or the top of the screen. And you will either find them in the 3 dots labelled More, and you will find there that it will say something about the chat. And it's quite easy there just to post a message and then press the enter key, which will post it on the chat. You can either post to everybody, or if you particularly wanted to post to somebody that's on here that you haven't seen for ages, or a message to me, then that's absolutely fine. Okay, so we're going to be using the hashtag Wales MHN 2020 for all you tweeters out there. It's been a bit of activity beforehand, which is always good. And so I thought I'd post up the conference plan for today, so you've all got a good idea of what's coming up. So, Croeso cynnes I chi gyd, a very warm welcome to you all. I have muted you all just for the sake of organisation, really. Otherwise, we might have chaos online this afternoon. If there's an opportunity to unmute people later on for some panel discussions, we'll do that. And certainly I'll be unmuting presenters, but you'll have a little bit of a warning before that happens. So please don't anybody try to unmute yourself. It's unlikely to work anyway. Okay, so we've used Eventbrite for bookings. This simply allows a little level of security so that the Eventbrite invitation has gone out far and wide, particularly aimed at nursing students in Wales, our universities, Swansea, Cardiff, University of South Wales, Bangor University, and clinicians in practice across all our health boards, service users, carers, a range of people. We may have people joining from England as well, which is fine. It's interesting to know how many people can join on a Zoom meeting. We had nearly 200 people booked for this, so it'll be interesting as we go through this afternoon to see how many people are here. And in terms of how did this conference start out? Well, some of you may know that for the past 20 years, we have had a South Wales Mental Health Nursing Journal Club, which has existed for the purposes of learning, growing together, participatory discussion. It's traditionally met at 3 universities. And a few people have said to me over the years, Julia, this should be with an online option. We should be able to video conference this. And so we've taken these comments on board. And of course, during current times, this really seemed like the ideal opportunity to continue with our learning. So next time you're thinking about an essay, or next time you're thinking about revalidation, certainly know that there are opportunities like this where we can get together, listen and talk and learn about mental health nursing in these changing times, which is really where the conference title very much came up from. Okay, so we will try to have a break at a point where it seems appropriate. And in a few moments, I'm going to introduce Hazel Powell to you all, but hopefully you've all had the opportunity to look at the conference and what's coming up over the afternoon. We are aiming to stick to time. Do use the group chat if you can, that will be extremely helpful. And any queries or questions, then post them on the chat, email me afterwards. I'm j.terry@swansea.ac.uk. And what we'll aim to do is like anything on the online, my suggestions are have a drink to hand, pen and paper, jot down anything that is of particular interest, things you think I'd like to raise that later or ask. The panel discussion is quite short. We've got service users from our group at Swansea who will be joining, Joy and Terry, and so particularly I think we may be posting questions. Equally, you can post questions to our presenters who will also be available. Okay, so I think that's enough from me. I'm going to stop sharing the screen, so hopefully you've had an opportunity to have a little look down and see what's coming up. After Hazel's welcome, we have got Ed Lord from Swansea talking about mental health nursing spaces and places. And we're going over to Cardiff then to Dean to hear about a number of different topics, particularly related to trauma and adversity. I won't read them all out because you've had that in front of you for a little while. Okay, so now we're going to go over with Hazel. Do just bear with me for a moment. There are a number of screens and it may just take me a while to find people. I found Hazel, so that's grand. That's lovely. Okay, so I'm very, very pleased to introduce Hazel Powell to you, who works in Welsh Government in our Chief Nursing Office. Hazel, over to you.
Hi everybody, I'm one of these people that waves on Zoom, so big wave everybody, hello. Thanks Julia, I'm absolutely delighted to be with you this afternoon, great to be part of today, and very much sure that events done virtually are going to be the norm going forward, so this is my first virtual conference or event, so I'm sure that's the same for other people. As Julia said, I work as nursing officer for mental health and learning disability nursing at the Welsh Government. I am a mental health nurse and a learning disability nurse by background. And I suppose like everybody else, my focus in recent months has been on COVID, and I'm just going to spend the next 10 minutes talking a little bit about that and giving an idea of some of the work that I've been involved in. So we know that as a result of COVID, there's a high level of anxiety and some psychological distress in the population, and that's obviously due to the health impacts of the virus and the consequences of physical isolation. People are afraid, I'm afraid of getting the infection, of people I know dying, losing family members, of dying. So people are very afraid out there, and people are more physically distanced from loved ones and peers, so that support, those support mechanisms that we usually rely on feel a bit further away perhaps, and some people, many people are facing economic turmoil, having lost or being at risk of losing their incomes and livelihoods. But it's also important to remember that these kind of emotional responses to the situation we're in are really normal responses, and not everyone will go on to develop a mental illness. The majority of people will cope reasonably well. For some people, they're real positives. For example, many people are enjoying the opportunity to spend more time with their families during lockdown. So don't get me on to homeschooling. And some people who find some of the societal demands and the pressures of transitions and unpredictability of others quite challenging, have reflected on some of the peace of having those pressures lifted. So for some people, for instance, with autistic spectrum disorder or social anxiety, there's some real positives around the situation we're in. However, there are clearly specific population groups that are showing really quite high levels of psychological distress, and that includes our frontline healthcare workers, of which many of you on today's event will be, older adults and people with pre-existing health conditions. Some of our children and adolescents are having their emotional difficulties exacerbated by family stress, by social isolation, through their education being disrupted and a lot of uncertainty about their futures that's occurring at quite critical points in their emotional development. And some people are facing increased abuse in their situations. We're finding that women are bearing a large brunt of the stress in the home, and we know that people from Black and minority ethnic groups are also having extremely difficult times at the moment. And then for some people with existing mental health conditions, the additional pressures and stresses for COVID may exacerbate those. There have been reports of some suicide attempts and suicide death worldwide linked to COVID, including some by healthcare workers, and a long-term upsurge in the number of people seeking mental health support and in people experiencing more severe mental illness is expected. There are some early signs that this isn't going to be any different in Wales. There's some early indicators that suggest that suicides may have increased in Wales in the adult and children and young people population, although for a wee caveat there, we've got a lot of work to do to look at that data, so it's just very early indicators that we need to drill down in and have a good look at. There are some reports that some people who've experienced significant trauma are finding that lockdown is re-triggering that trauma, and there's reports of relapse from people who are dealing with substance misuse. And there's some increases in referrals to some of the homeless charities due to family breakdown. So we are seeing those early signs that would suggest it will be no different in Wales than the rest of the UK and beyond. So there's been a number of changes to the way that mental health services have been able to work during the pandemic, and people work with people and their families, and community mental health teams have needed to make individual decisions with families and people about meeting the need and meeting their support needs at this time, and avoiding hospital admissions with an emphasis on community provision has been a fundamental principle of this. And where it is in the person's interest to continue an assessment or intervention, this has been done where possible via virtual means. And so we've made massive leaps forward in terms of some of the digital transformation work that we've been trying to do over recent years, and such virtual and remote approaches can be effective and scalable. However, there are limitations, and there's issues around digital literacy, privacy, confidentiality, less internet or telecoms access in some groups. So such approaches aren't the answer for all mental health needs, and it's important we remember that, and that other modalities of care continue to be important. But what we have seen in services has been a focus on liaison, in working in partnership, and stressing the importance of maintenance of well-being with mental health monitoring and support, and areas have needed to support people with many challenging conversations. And there's been a real fear that people who use mental health services will be treated differently because they have mental health needs. And in addition, the current restrictions, I think, are impacting disproportionately on these groups, and for some people the ability to understand why society around them has changed so abruptly can be challenging. We've also seen some really positive examples of co-working between health and local authority, and crossing between inpatient and community services to help maintain people within their own homes with support. And we've seen more in-reach approaches than perhaps previously. In some areas have increased kind of well-being checks, meaning that some people, in some cases, there's more contact with their community teams than they might have had previously. There's been a lot of national policy approaches, a lot of work going on nationally, and some of the bits of work that I've been involved in have included things like developing arrangements for the emergency mental health powers linked to the coronavirus bill, which we've not had to enact in Wales or England, and it's unlikely, hopefully, that we will enact those changes now. We've made amendments to allow people who have mental health needs and learning disability or autism to go out more often to support their health and well-being. We've been monitoring bed capacity and procuring additional capacity where required. We've been providing advice and guidance to NHS and independent providers for escalated issues. We've looked at funding an enhanced Health for Health Professionals Wales services, which is around trying to support people on the front line. And we've been reviewing early data from serious untoward incidents to try and identify themes and early learning to support service response. There's been a lot of work going on around strengthening of Tier 0 support, so developing mental health, public health advice on Public Health Wales and the Call Mental Health Helpline, working with Call to boost resilience of that helpline and weekly monitoring of capacity, and identifying and assuring digital platforms and resources to support mental well-being, and trying to invest in mental health interventions that can be delivered remotely. So going forward, there are a number of areas that will be important, and these are being considered as part of our kind of planning for the next stage. There's something for me around understanding if and to what extent the lack of routine assessment services, face-to-face therapy and the withdrawal of day service care in some instances has impacted on people who experience mental ill health. There's ensuring that our guidance hopefully, the ensuring people with mental health needs are receiving information in a timely and accessible way. And I think often the population version of guidance is agreed, and then services need to make sense of that for those who use our services. And I think sometimes that's challenging. There's learning from working virtually, including gaining an appreciation of what kind of work would not be appropriate to be carried out virtually. And there's a need for guidance and training for staff to support greater use of video technology and assessments and therapy where this is appropriate. And also part of that gaining an appreciation, I think, is around understanding the professional issues from home working. And those are issues around professional boundaries, privacy, dignity, the appropriateness of the environment where staff undertake their assessments and supports. Going forward, I think messaging is important. Messaging can be helpful or harmful, and there's a real need to talk about mental health and suicide in a way that positively encourages help seeking and avoid negatively influencing behaviour, and avoid messages that indicate that mental illness and suicide is a common or acceptable response to COVID, whilst recognising the particular stresses that the situation brings. There's a need to continue strengthening Tier 0 support, including providing good general mental wellbeing information and advice and support to the population as a whole, and clear signposting to the range of third sector organisations that can support with that. And we're doing some rapid evidence gathering to assess the impact of COVID-19 on mental health and to assist service planning and that demand and capacity planning at health board and national level. And as well as thinking about what we want to retain, so we talked about some of the progress made around the digital transformation, we're also having conversations about what it is important to roll back. So for example, in mental health nursing, we've seen our community nurses in some areas move into wearing uniforms, and we're having some conversations nationally. Is that something that we want to become the new normal? And and how do we stop that maybe becoming the new normal? Let's have a look at the pros and cons of that. And also some areas have locked doors more often to prevent the spread of transmission. And again, there's some conversations around how do we make sure that doesn't become the new normal. So that's our whistle stop tour. I'm going to stop there and say thank you for listening. Really, it's a really interesting agenda today, so I hope everybody enjoys the afternoon. I'm staying around, so if there's any questions, I'm happy to pick them up in the sidebar, but I'll hand you back to Julia at the moment. Thank you.
Okay, so Hazel, thank you very much indeed. It's interesting to see how mental health has suddenly come far more into the public domain with lockdown. So there's a very, very quick poll for you all, just to find out who's in the Zoom room. So are you attending this conference as? So if you're just able to click in whatever is the appropriate answer for you, you can only choose one option. So given that there's now 119 of us in the room, it's quite interesting to know who's here. This conference was aimed at a range of different individuals, and we are so pleased that you can join us all. Okay, so I'll just keep that open for a little bit longer. Most people have replied. We won't have loads of this during this. There's only a couple of other questions which will appear much later on, just so you're aware. Yes, it's interesting, isn't it? So not only in the press and on the TV, but mental health has had far more focus over the last 12 or 13 weeks, which I guess we're all pleased to see it much higher on the agenda. Okay, so I'm going to end polling because I think most of you who are going to vote have properly voted. And so who's in the Zoom room? Well, let's see. We can share the results. And we can see that the majority of people here are nursing students, quite a number of people working in the NHS, mental health nurse academics, government policy. Hazel, I think that's probably you. A few others, and so we may find out a little bit more about people who are in the room later on. So that's extremely helpful. Okay, and so I'm just going to lose the poll now, and I've got a few co-hosts this afternoon, which I'd like to introduce. And so, Jamie, if you just want to say who you are.
Hi everyone, my name is Jamie. I'm a lecturer at Swansea University. Nice to see you all.
So also I'm joined by my colleague Martin. If you just want to share and say, Martin, who you are.
Hi all, I'm an online learning officer for nursing. Nice to meet you all.
Thank you very much. So I'm very pleased to have Jamie and Martin here this afternoon. It's nice to always work in partnership with other people, and we don't do anything without working with others as part of a team. Okay, so when we're ready now, we're going to continue with the group chat and any questions, and we're going to move over now to our first talk, which is from Ed Lord at Swansea University.
Sorry, Jamie, I think we can't hear anything. You have to unmute yourself, I think.
That might be my fault, sorry folks.
Good afternoon, my name's Ed. I'm a mental health nursing lecturer at Swansea University, and this afternoon I'm talking about mental health nursing spaces and places. I'm interested in mental health geography, geographical approaches to health more generally. And just to start off with, I want to be really clear about what I'm not talking about. There's a common misconception that mental health geography and health geography more widely is only about plotting the incidence and distribution of certain diagnoses on a map. This is related to epidemiology and kind of thinking about big data sets, and often involves the use of geographical information systems and kind of techie approaches like that. I'm sure we're already familiar with the value of these kind of things from the recent months during the COVID-19 situation. But what I'm talking about is spaces and places as felt, negotiated, and thoroughly social. I've got a quote here from another Ed, from Ed Sheeran. He says, "Baby, I've got the feels," and it's all about how things are felt. Some geographers talk about how spaces and places get under the skin, how we're in spaces and how spaces affect us and how we in turn affect them. Ingold talks about the environment is a world in which we live in, not a world we look at. And he's interested in how we inhabit our environment. And these are the kind of things I want to explore here. I want to get you thinking through how spaces can be affective. For example, they can help or hinder, how can they help or hinder mental well-being, and how spaces and places can be changed. And this whole thing about changing them is kind of crucial to this, to see where you can make action, where you can make things happen, and how that can happen. And I think that's key to the nursing role. As a way into the field, today I'm going to, as a way into introducing spatial theory, I'm today going to use a key thinker in the field, Henri Lefebvre. He was a prolific author, so for now I'm referring to his seminal work, The Production of Space, from 1974. The key takeaways from this piece are that space is not an empty container separate from human social life. It isn't just the stage on which we're acting, on which things play out. It's not just a background, something that's inert. His point is that space is socially produced in a complex back and forth. He's a Marxist, they like to talk about dialectics. So it is changed in a back and forth, in a like trying to fit a door into a frame. You take a bit off the door and you take a bit off the frame, you make it fit. And that's what the dialectic is all about, this kind of back and forth. And this is how space is produced. He proposed that space is produced through a three-way or three-part interplay. The spatial practice, the material spaces as seen material space as seen and used, actual concrete real space in which we go about our everyday lives. Lived space, the social space of ideas, imagination and layers of meaning, the things that we're bringing to the space, and how these are playing out in it, and how that influences what we think of it. And the conceived space, the space of planners and management, quite abstract things. These things often involve maps and models, plans and concepts. And Lefebvre is saying that social space comes together through the interplay of these three things. For this session, I want you to think about how this three-way triad, the space as social practice, lived space and conceived space, plays out in our role as mental health professionals, but also how it plays out as the individual negotiates their mental well-being, whether that's service users in mental health services, or whether that's us or any individual working out our mental well-being from one day to the next. We'll start off with spatial practice. I want you to think about what are the rhythms of this space. Whatever space it is we're thinking about, whether it's a ward, whether it's our everyday spaces of social negotiation, our workplaces, what pub we go to, where we like to be, where we see our family, what parks we use. And what are the rhythms of this space? Is it based on the light and dark cycle? Is this influenced by day and night? Is it a shift working pattern? How are the spaces being used? How is a ward laid out? Where is a day centre or CMHT office located in a city? And how much agency does a person have in deciding or altering this use? Here's some images to illustrate this idea of spatial practice. We can use corridors to get from one place to another, thinking again about where's the CMHT based in a city, how space is used. This image here is a hospital I used to work in, and a lot of people, staff and patients, used to congregate along this river to smoke, or just as an informal social space, and potentially not what the hospital planners had in mind. And how do we negotiate the spaces? What transport do we use? For instance, how do I get to a place? If I want to get to work, do I cycle the most direct route? Do I cycle the most attractive route? And possibly the interesting thing is how much of this is in my power to decide, and how much of this is dictated by the shapes, forms of the city, the spaces around us, and who owns these things, who has power in these things. And I think we've seen this recently with the whole Black Lives Matter thing, and how people of different races experience spaces differently to how I would experience them, and how they're restricted from spaces that I would feel safe going into. And that's a really important thing to think through in spatial theory. Moving on to Lefebvre's next part of his triad, the lived space. So what ideas and meanings do you have about the spaces that you're using? A really interesting way to think about this is, what associations does the word asylum have? What is therapeutic about certain landscapes, or the opposite? And how could this space be different? Can you imagine how? It takes the imagination, it takes the thought that something could be different. And how would you be able to change this space? That's the view from Kevin Coyd. What imaginations does that have for one person that it might not have for another? Watching a beautiful sunset from a ward, a meeting space in another hospital that I worked in, and then a part of Berlin that would have been dangerous during the 1980s, but right now it's somewhere that the children can play. And what imaginations are we bringing to these spaces? And finally, the third part of the triad is conceived space. What was and what is the plan for this space? Where is this plan coming from? Is it an external source? Who is implementing and enforcing this plan? How is this being promoted, negotiated, or resisted by those using this space? And I think the whole idea of social distancing has really brought this idea to the fore. there's this whole image of what it looks like to be 2 meters apart and how some people are and some people aren't. So think through where are the plans coming from, who's making the plans, how are these affecting us, and how are these unfolding, and are the ways we're using spaces now what was originally planned for them, and how are we adjusting that and changing that, and this is all about the negotiation of space. So I just want to leave you with some further reading in the mental health and space field. I hope I've piqued your interest a little bit. It can seem quite abstract and quite challenging to get into, but I think there could be some really fruitful ways of thinking about how we're changing things and how we can change things, and how spaces can be more therapeutic. So I want to recommend Mental Health and Social Space by Hester Parr, Space, Place and Mental Health by Sarah Curtis, and I published last year, 2019, this one, the Handbook of Mental Health and Space, which is edited by McGraw and Reevey. And I'm going to leave you with a really specific one of the chapters from that latter book. It talks about how spatial practices and spatial theory can be applied to a very specific space that a lot of us will be quite familiar with in the mental health field. So the use of a smoking room on a mental health ward. I just really hope that can kind of pique your interest and get you looking at spatial theory in more depth.
Thank you, Ed, so much for that. That was very interesting, fascinating to see that chapter there. So I think when you think about spaces and places where we work, where we connect with people and what that means, it's very varied for all of us. And whether you might be a nursing student who's worked for some of your time on an allotment next to people as part of a placement, or you've been on walking groups, it just means a whole host of different things to all of us over time as well. I'm sure we'll be meeting Ed a bit later on again, and he has a very interesting role because usually Ed works 3 days a week in a woodland space, and I'm sure we can find out a little bit more from him a bit later on. Okay, so we're coming over now to Dean Wybrow, and I'm going to mute again and over.
Hello, my name is Dean. I'm a mental health nurse, a lecturer at Cardiff University, and I'm a veteran. I served close to 20 years in the armed forces, delivering occupationally focused mental health care. The aim of this talk is to share some ideas about how to support the workforce when they're facing sort of adverse situations. And to do that, I'm going to pin some of what I talk about upon psychological trauma. And so I'm going to explain how people react to traumatic events. And then I'm going to describe how the military support their workforce based upon my experiences. And then finally, I'm going to summarise what is being recommended for healthcare workers in the civilian world at the moment, and to consider some of the similarities between the military and the civilian approaches. I hope you find it helpful. So psychological trauma. I explain this to patients who I help, and student nurses who I teach, and other healthcare professionals who I offer CPD to. In the same way, I use this diagram. My art's not good. So just to tell you what this is, it's not a tower block, it's a filing cabinet. Who knew? And in charge of this filing cabinet is a clerk, and this filing cabinet and this clerk are in your brain. The clerk's job is to take experiences and to turn them into memories that they file away in the filing cabinet. Once in there, they're a bit fuzzy around the edges, a bit vague at times, a bit like stories. They have emotion attached to them, but it's nothing like as intense as it was at the time. It can be negative, can be positive, can be neutral. It's a really effective system, apart from the clerk doesn't like to file away life-threatening, overwhelming, traumatic type experiences. And it puts its gone to lunch sign out, but the experience still needs to be turned into a memory. So we have another room. No filing cabinet, no clerk, it's just a big jumble of memories. Now, where these ones are vague and fuzzy around the edges at times, these are not. These are vivid. The emotion is very intense, often very upsetting. It could even feel like it's happening again. And people will go to great lengths to avoid sparking off these memories if they possibly can. Now, what then happens is that over a period of time, hours, days, months, the clerk likes to do some housekeeping, and they might take a memory from here and file it in the filing cabinet. Once they do that, it settles down a bit. It's still going to be a negative, upsetting memory, but it won't be as intense. It might even get a bit fuzzy around the edges. That's the normal process of recovery when we're exposed to traumatic experiences. Now, post-traumatic stress disorder, so a psychological reaction that doesn't go away, is when this normal process of recovery gets stuck. Within the armed forces, what we know from veterans is that it can actually take people quite a long time to seek help, and that's reducing. It's much quicker for people from Afghanistan and Iraq type conflicts, the Northern Ireland, for example. It can take people a long time to seek help, which is unfortunate because therapies are often effective and they're quite brief, so 3-4 months potentially sometimes. So if somebody's waiting potentially 16 years to seek help, struggling with these memories, it would be really nice to encourage them to access that help much, much sooner, and within a few months they might be moving towards recovery. And that's the principle that kind of underlies the military approach. Now, this is something after my own heart, pie. I really like to eat it, but the principles work for forward psychiatry, which is psychiatry or mental health care delivery within an operational environment. And it's based upon this idea of proximity, immediacy, expectancy, and simplicity. So you don't bring people back to the rear echelon, you go and see them where they are, or as close to where they are as possible. Much easier to work out what's going on and help them to stay there if you go and see them there. You do it straight away or as soon as you possibly can, with the expectancy that people can recover in that situation and actually be with their colleagues and their peers, which is often better for the resilience in the longer term, is the theory. And you keep the intervention simple. So food, rest, maybe a shift of role from something that's high demand to something that's low demand, for example. So that's a basic principle that informs the kind of work I do, but there are some organisational interventions too, and the two main ones are TRIM and POSM. TRIM stands for Trauma Risk Management. So essentially what happens in the forces is that lay people, so the colleagues, the peers of the individual, somebody's corporal, another private, a sergeant, will be psychologically aware and trained in something called trauma risk management. So if an event occurs, their job is to get a baseline for how everyone's doing, where they're at in that normal process of recovery. And then a month later or so, they'll check in again to see how people are, and even 3 months later. And the principle is to notice those people who are getting stuck so that they can be signposted to help sooner. Once an operational environment is left, so a group of people leave a war zone, for example, then there's a post-operational stress management policy too. This is about creating a buffer for people so that they can readjust to normal working roles and connect with their families again, etc. It also involves another opportunity for line managers to check in with how people are doing and again facilitate them accessing help if they need to. And that's the principle. Now, here's some recent recommendations that might be relevant to the NHS. This is from the World Health Organization, and this came out at around about March time, I believe, as part of the response to COVID-19 public health crisis. So they made 3 sets of recommendations for individuals, for managers, and for the organisation as a whole. For the individuals, what they were doing was normalising feeling stressed. So a bit like my example of that normal process of recovery. It's normal to have a reaction, to have these vivid memories for a time, for example, normalising the fact that people will feel stressed, and people do. TRIM sits within that principle too. But then recommending some simple interventions: food, rest, exercise, time with family, for example. Then for managers, it's saying, you know what, you need to model this. If you're going to ask the people who work for you to engage in these strategies, you need to do it too, and to demonstrate that it's happening to you and you're all in this together. Also, it's beholden to the managers to raise awareness of the mental health care provision that's available, and then importantly, to reduce the barriers for people to access that type of help. And finally, at the organisational level, it's worth considering rotating staff from high demand to low demand roles and back again, and to ensure there is effective and accurate communication of information, so everyone is joining the dots up in a similar way or on the same page, so they understand the bigger picture. The Royal College of Psychiatrists have also made some recommendations, and they talk about downtime to adjust when returning back to normal duties. They talk about acknowledging what staff have done and thanking them for that, and showing them gratitude and celebrating it, formally if possible, and promoting cohesion and team morale wherever possible, because that will promote resilience. In addition to raising awareness of how to access mental health support, and then here's something interesting: managers carrying out a structured return to work after the COVID-19 is over for that individual, and they're going back to their normal work role. So this is an opportunity to check in with how people are doing and to signpost them to help if needed, and also to manage the environment a bit if needed as well. Finally, they talk about writing to people 3 and even 12 months later, just to remind them of how they can seek help, which are really neat ideas, I think, too. Okay, so what are the similarities between the military and the civilian approaches? Well, here's some lovely pictures of some pies. I talked about the principles of pies, people getting fit, TRIM, and I'm really stretching it here with my picture of a possum to reflect POSM. But there are some similarities between these 3 approaches. You will notice that some of the recommendations that came out of the World Health Organization were about short, sharp interventions to help people. Eating some food, getting some rest, changing role for a while, all simple pies type strategies in my mind. Very, very sensible. You will notice that there was this idea of peer support. So line managers modelling what they're asking their workforce to do is a bit like the TRIM principle, because those line managers will be in similar types of roles or in the same sort of cultural group. So that makes some sense to me too. And finally, you've got this idea of people having a formal structured interview upon return to their normal role, and having some bedding in time before they go straight back into their normal role after the COVID-19 crisis has settled down for them, which very much fits in with these principles around POSM. Another really good thing which the NHS is doing in Wales at the moment, which also fits with all of this and probably fits in with the immediacy part of pies up here, is they have opened up access to wellbeing support through health for healthcare professionals, I think it's called, which is a phone number that people can ring and access free CBT, guided self-help, etc., but psychological wellbeing support essentially across Wales for all healthcare professionals and student nurses, which I think is a really good idea too. Okay, so that's my presentation. I'm coming to my 12-minute end point to allow some time for questions, and I hope you see that there is a system within the armed forces which actually resonates with what is being recommended for healthcare workers at the moment in response to the COVID-19 crisis, both by the World Health Organization and in the UK. Happy to answer any questions that you have over the next few minutes. Thank you for your time.
Dean, thank you very much. That was extremely informative and very, very interesting, particularly to think not only about people who've maybe been on tour, whether it was recently or a while ago in the military, but also about our own experiences and about some of the kind of new normals. So I'm just having a little look here at the chat and at the conversation. So interesting to hear about different services that are available. It'll probably take me a little while to find Dean on Zoom. So I'm not seeing any questions coming in on the chat at the moment. Jamie, if you can find Dean and want to unmute him, that'll be great. I shall just be whizzing over all the different screens. There's so many of you on here. It's great. We're 116 at the moment. I'll give you little updates as we go through the afternoon. There's Dean. So Dean, I'm just asking you to unmute. I don't know if there's any further comments. Oh, here we are. We've got some comments here asking about rotating of staff. Really difficult to get staff to volunteer on our COVID ward. I'm not convinced we could easily rotate. Dean, I'm not sure if you've got any comments. There's quite a specific question there.
Hi Jane, nice to meet you. I hope you can hear me. I think I'm unmuted, lovely. Yeah. Well, not really. I suppose the principle is what I was talking about. How you'd apply it within your place of work is something you definitely have more expertise about than I do. But I get the challenges to that as well. And how you might need to manipulate that principle to work better for your place of work. But I haven't got any kind of clear direction that I could offer because that's not within my gift. I'm sorry for that, Jane.
I think it's just it's useful for us just to consider the variety of tasks for all of us at home, whatever roles that we're in. If we're working, if we're retired, if we're doing a programme. And just to think about some of those daily shifts that can actually make quite a difference to our own mental health. And that's a nice link for me back to Ed's conversation about spaces and places, the notion of getting out, being outdoors, using space where we have that accessible to us, different for people who are shielding, for sure. But actually just that being out in the fresh air, for those of us who are lucky enough to have gardens, I think have been an absolute blessing to many people during lockdown. Okay, so we're lining up now for our next slot. So I'm pleased to welcome Dr. Anne Fothergill from the University of South Wales. Maybe from my persuasive talk, Anne agreed to run this session as a joint interview. So Anne is providing us with some personal reflections on the changing face of mental health nursing from her perspective.
I'm delighted to be joined today by Dr. Anne Fothergill, who is Principal Lecturer in Mental Health Nursing at the University of South Wales. Welcome, Anne.
Thank you, Gia.
So we said we'd run this as an interview and take the opportunity to ask you some questions about how mental health nursing has changed, things that you've seen in the course of your career. So Anne, can you tell me, how did you begin your mental health nursing journey and why?
Okay. I started training in the early 80s, which was a very different time to do nursing training then. It was because my mother was a nurse, and before that my grandmother was a nurse, and I think they encouraged me to go into nursing. So it seemed quite a natural thing to do, to go into nursing because of my background.
So what was different about your nursing student journey maybe to today's programmes?
Yeah. We were counted very much as part of the team. We spent most of our time in practice on placement. So we had long placements up to about 12 weeks at a time, with the occasional week in the School of Nursing, because I didn't train in university. We had schools of nursing then. So we spent maybe a study week in the School of Nursing and occasional study days, but most of the time was in practice. We're not supernumerary, we were part of the team. So that was very different. So I think that's that experience that sort of was very much more of a hands-on kind of approach. It was very much a traditional training course, less focus on the academic side and more focus on the practice side of nursing.
And I mean, in terms of similarities, would there have been more similarities or differences? What can you tell us about that?
I think there was more differences really in the programme. The programme today is very different to my experience of training. And we always think the training we do is the best training. But, because, we're sort of biased to think that my training was the best training because it's the experience that you've had. But I think that just the fact that there's a 50-50 split now, there's more focus on the academic side of nursing, more focus on it being evidence-based practice, so that research needs to support practice. That wasn't very much part of my training. It was about learning skills, building up knowledge. So that's where the main differences were in terms of the training programme.
Can I ask you your favourite placement when you were a student?
I actually enjoyed all my placements. There wasn't really any that I had a favourite, but I think in terms of how I got to become a mental health nurse, I started off as a general nurse initially. So I did 3 years as a general nurse, which I enjoyed, and I wouldn't change that. But going into my first mental health placement as a 19-year-old general student nurse, it really opened my eyes to mental health nursing. I hadn't thought about mental health nursing before that. But my experience was kind of a mixed experience. It was in a big, old asylum hospital, which was like a prison, really. It was on the outskirts of Canterbury, where I did my adult or general nurse training. Big hospital, 1,000-bedded hospital. Very scary place in some ways. The care was very much around institutionalisation. There wasn't very much therapy going on. And I think from that experience, I really enjoyed working with the patient, that experience. And for me, I felt there had to be something better for mental health patients, something that was more focused on being therapy and engagement, because there wasn't very much engagement with the patients on what I could see between the staff and the patient. And that really made me think, this is what I want to do. And that wasn't necessarily my favourite placement as such. It was really the one that's changed my kind of future. And that's from that placement, I decided then I really wanted to be a mental health nurse. So I waited till I qualified as a general nurse and then went on to do my mental health nurse training later.
Okay. So how did your career as a qualified nurse start?
It started in Canterbury in Kent as an adult general nurse in 1981. And I spent 3 years trained as a general nurse, qualified as a general nurse, and then worked in a coronary care unit, my first job. And then from there I worked in a medical ward, and then from that I actually thought, okay, I enjoyed this type of nursing. The opportunity came up to apply for a post-registration, what we call post-registration course in mental health nursing. A training place came up in Guy's Hospital in London. And I had a choice then. I thought I'd been offered a post to work in Canada, the opportunity to go to Canada, and I thought, oh, what do I do? A real dilemma. Working in Canada would have been a fantastic opportunity experience. And I would have had a sponsor there, had a job there. And then Guy's Hospital in London offered me a mental health nursing place. So my choice was to go and do my mental health nursing. I don't regret that. It was probably the best decision I made. And yes, and it was in a big teaching hospital, which I always wanted to do, work in a big teaching hospital. It was a shortened programme. It was only 13 months in length, which was the shortest programme in the UK at the time. Most post-registration courses at the time were around about 18 months in length. So it was a very short programme. And looking back, in some ways, I wish I'd done the full 3 years to be a mental health nurse rather than 13 months. But it gave me enough insight into mental health nursing and to know that I'd made the right choice.
Can you tell us some of the highs and lows of your first few years as a qualified mental health nurse?
I think that when you qualified then, it was very different. You were handed the keys as soon as you got your PIN. It was a kind of sink or swim approach to being a qualified nurse. As soon as you had your PIN number, you were expected to be in charge. There was no preceptorship. So in some way that was kind of not so much a lull, but a challenge, that you, as soon as you qualified, you were then in charge of the ward. I mean, the highs have been really just that whole experience of working with people with mental health problems. My first placement, my first job as a qualified mental health nurse was on an acute psychiatric ward in Guy's Hospital, sort of central London. So there's lots of challenges with the client group that we work with, service user group we work with. There was high level of deprivation, you know, kind of lots of quite very unwell people, quite sort of violent people sometimes that we worked with on the ward. And I think that was certainly a challenge. You know, the first experience when we had somebody came home with a machete, that was quite an interesting experience. So that was a bit of a low in that sense, been quite a challenge. But the highs have always been really, for me, working with people with mental health problems. That I just love doing that. So I've learned so much from the people I've cared for. I think it's really important that you have a sense of humility when you work with people with mental health problems. And I felt I've always been quite a humble sort of person, and just really very respectful of people with mental health problems, and just want to feel like I'm an advocate for them, to sort of support them to have a better life, really. And that really stemmed from my first experience thinking there has to be a better life for people with mental health problems than be locked up in an asylum and institutionalised. So yeah, I think that's the highs have just been really, for me, just learning from patients. We've learned so much from them. They've taught me so much, and I've enjoyed probably everything I've done, really.
People often talk about key experiences or decisions that have shaped their nursing journey. Would you like to tell us something about those?
I think really the shape of my journey has been really my enjoyment of working with students. Actually, I really enjoyed working with students on the ward. I used to take every opportunity I could to sort of teach them. You know, quiet time on the ward, let's go and sit down. What do you want to learn? What do you want me to teach you? What do you want me to do for the next week's teaching session? I used to implement quite a lot of teaching sessions on the ward, which I thought the students enjoyed. And I think that started me thinking then, I really enjoy this side of my job, mentoring, you know, teaching student nurses. And that started me thinking then about future. Where do I want to go in my future? I suppose that's really led me to where I am now. I started then thinking, I need to get some academic qualifications, because at the time, you know, we need to get a degree, possibly master's qualification. So I took a decision after a few years of working as a nurse to go back to education to do my degree. And then I went on after that to do a PhD. So I didn't kind of quite go back into teaching straight away. I went on to do a PhD. And then I got my first nurse and lecturing post 24 years ago now, almost 24 years ago. I think it was when I started at Cardiff University as a lecturer in nursing. So I think for me, the kind of journey's been really enjoying the practice side of things, but also enjoying the contact with students, the teaching that I did with the students, and then wanting them to go on to be a nurse teacher or a lecturer.
Thanks, Anne. So we've just got a couple of minutes left now. So for my final question, I'd just like to ask really about some of the changes that you've seen that have impacted maybe on your role, particularly in the last 10 years.
Okay. I think there's been so many curriculum changes in nursing, but I think for me, the biggest impact for nursing was when we became an all-graduate nursing. I think it was long overdue. And I think it's really changed the status of nursing to the public and to everybody else around us, that nursing is much more autonomous profession now. It's seen as a profession. Certainly when I trained, we weren't seen as a profession, it was more of a semi-profession. And I think nurses having that opportunity to exit with a degree and then to go on to further their education to master's level and to PhD level has actually really raised the profile of nursing. And I think that to me is really the biggest change. And I'm quite pleased that I've been along on that journey, because I've always been a supporter of nurses developing themselves to their optimum ability to become the great nurses that most of our students do become, and seeing them develop and seeing them go on to be leaders and to inspire other student nurses in the future. I think that's to me is a big change. So I'm glad we're not, you know, in the days of the traditional nursing profession, that we are an evidence-based profession. And I think that's certainly the way forward.
That's great, Anne. Thank you very much indeed. Now this is a great opportunity for us to take any questions from the audience.
Thanks, Julia.
Okay, so that was really helpful, Anne. Thank you very much. I do apologise to everybody for the filming. That was down to me and my internet at the time, so my profuse apologies to Anne. You've all been very patient with us this afternoon in terms of experiences. So we wanted to build in a short break. It's a long time for us to be sitting at screens. So I've got a couple of minutes past 2. Please take this now as a 5-minute drink and stretch break. So this is your time just to grab 5. Okay, back in 5. Remember, if you've got your camera on, they're still on. So coming to the end of a very rough, fast break, everybody. Some really interesting comments in the chat there, and certainly about dual registration, which came up in Anne's interview there just now. And we've started to see more of these programs developing, I think particularly in England, some of them where pre-registration programs of over 4 years, sometimes at master's level, where it involves a dual registration, because during the amount of time we've not had those courses, people have continued to ask about them, and I think we can all be aware as to why. There's enormous merit. I still come across many colleagues who have got dual registration. I think probably in our team at Swansea there's only 1 or 2 people now who have dual registration, but this was certainly extremely commonplace. Okay, so I'm going to be back muting myself, and I'm very pleased to introduce Professor Michael Coffey, who's going to be talking to us about risk assessment, thinking about how we talk about risk, and what this says about our mental health system and how we make sense of it all. Michael.
So today is going to be a quick skim over the top of this. Much of the literature focuses on a set number of questions, and these are things like what is knowable about risk and safety, and can we measure it, and if we can, how do we go about doing it? And to a lesser extent, there is a growing awareness that all of this activity or focus on risk might not be so positive, so that we're getting a movement towards critique along the lines of what are the effects of risk thinking on practice and on people. So risk assessment and management, and to some extent its measurement, is a recurring issue for mental health services. And it's a real issue, of course, because harm does occur. So that there are about 5,500 suicides in the UK each year, 30% of which are known previously to mental health services. And there's been some recent increases in men in particular, which seems to be associated with economic austerity. And we don't even know yet about COVID-19 or the lockdown and what the likely outcomes in relation to safety and risk that might accrue there. Risk assessment is a key requirement of the policy that you will know about in secondary mental health care in relation to the care programme approach in England and care and treatment plans in Wales. But there is little doubt that some form of risk and safety procedure is going to be required in services. The problem really is that our knowledge is limited, and that risk assessment procedures that do exist, even if we really believe they do what we think they do, are rarely consistently applied. And within the mental health system and in society more broadly, there is a contrast between perceptions of what are referred to as high profile, low probability risks, such as a homicide, for instance, that lead to calls for interventions, and low profile, high probability risks that are seemingly accepted without concern. Judgments about risk tend to highlight certain risks, and they tend to downplay others. So common everyday or ordinary risks that a person might experience are rarely considered in mental health assessments. And so this indicates a potential mismatch between what the worker is concerned about and what the patient is concerned about. Much of our knowledge, it has to be said, is based on what workers see as important rather than what patients see as important in risk. We must also see that risk assessments, even poor ones, are consequential. There are potentially serious implications for people in that their risk assessments carry significant weight because they determine continued liberty. And for workers, they also represent the means to avoid or apportion blame for untoward events. What this means then is there's a tension sometimes between outcomes that promote independence say, and those that shield workers. So for workers, there remain significant concerns about what might happen if something occurs in mental health services that they were unable to identify and predict. For patients, there's a concern that the restrictions that are placed on their liberty are done so without any real evidence that these help, and in some cases that the restrictions and impositions themselves cause harm. So on this slide here, we're looking at a slide here from a study I did with people who are leaving forensic hospitals. So what I want to say here is that how we talk about risk implicates how we understand ourselves and how we orientate towards each other. The implicit assumption being made in much of what we see in the mental health risk assessment practice is that the identity of the individual is fixed and immutable. So once we've labelled something, it must be forever labelled. So if we have had a mental health problem, we are forever mentally ill. If we once stole a bottle of milk, we are forever a thief. If we once got involved in a physical fight, we are forever violent. And this causes all sorts of potential problems for individuals, especially if services, so for instance, in this case, forensic mental health services, see their primary purpose as public protection, while also trying to support people to recover and to reintegrate into communities. As I said, these data are from a study that I did of people leaving forensic settings to live in the community, and it shows how individuals must negotiate and handle the transition and how they accomplish identities in the context of attempting to pass as usual community members. For people using those services like Tony here, there is an awareness of the weight of social judgment that can come to bear down on the individual. Tony has moved back to live in the community setting following a number of years in forensic inpatient services, and he indicates a fear of what local judgments might mean. What gets prioritised in risk assessment is evident in the language that gets used. The priorities also don't match up to the incidence rates. So, for example, the fear of violence to others is a major concern for services, but it's actually far less common than other risks. Risk language has been noted to be largely negative and inclined towards unpleasant outcomes. Hence, workers and perhaps even service users and the families too appear to buy into or create a set of fables which may work to preserve working relationships and would otherwise be challenged, by a focus on assessments that have limited value in themselves. So workers may choose to hide risk assessment processes for fear of causing concern, but also because they may not have confidence in them as robust judgments of risk and safety. The problem that can occur, however, is that service users and their families worry that their safety has not been actively considered, and they are concerned that workers are only concerned with risk that implicates them for potential blame. So in our COCAP studies, we found that only about a third of care plans actually showed evidence of a risk assessment having involved a person, and that workers very seldom involve the person in the actual management element of the plan. So here you see a service user expressing concern that his safety is not being addressed, and that this might be a lower priority for services over harm that he might be seen to cause to others. And then the worker implies that identity is very much implicated in the outcomes of risk assessment. We found that many practitioners of all types did not share risk assessments with service users. And in doing so, they denied people opportunities to participate and to show agency in attempts to address their own safety issues. In healthcare settings, Langan noted that Professionals were only concerned with risks for which they themselves might be held accountable and blamed. So that, for instance, we don't tend to see much in the way of activity about structural risks, but lots of concern that workers might be in the firing line if an error in professional handling of danger occurs. Another feature of the literature is a criticism of the dichotomy generated between the supposed objective judgments of experts and the subjective judgments of lay people. Professional judgments are constructed as rational, and lay judgments are positioned as contaminated by cultural elements. And this is seemingly presented without an awareness that professionals themselves may be subject to the same cultural influences as lay people and their patients, and that value choices are always being made in defining what is a risk and to whom. It also means that there's an important knowledge contributions from individuals are being ignored or sidelined. Well, one problem with the risk literature focusing on individual behaviours is that it can fail to take into account ideas of positive risk and risk by choice, or for instance, engaging in risky pursuits. Individuals are not just scanning the horizon for things that might be dangerous in some sort of hyper alert fashion. They're also making choices to do risky things. Doing risky things like getting a job and experiencing more stress can help us grow. Much of the literature and many practitioners refer to risk as coming from the person. They propose the idea that risk is embodied within people who experience mental distress. And there's little awareness, for instance, of the limitations of this approach, or indeed, or even what it ignores or downplays. One element that is downplayed, ignored, or just not prioritised is safety and risks experienced by people who have mental health problems in news services. Here we see Douglas's assertion of the cultural embeddedness of what risks get attended to and what risks are left unattended. Could it be perhaps that Langan's point about staff only being interested in risks they themselves could be blamed for is what we are seeing? There's limited literature on risks experienced by service users for sure, but we do know, for instance, that there are risks for them from their contact with services, not least of which the imposition of toxic and potentially life-threatening chemical treatments, but also restrictions on their liberty. And there are also many social risks, including stigma, discrimination, physical assault, domestic violence, poor housing, poor unemployment, and poverty. In our studies, we found not only did risk assessments not get recorded, but also that service users themselves were largely unaware that they'd even occurred in the first place. This is not a new finding, unfortunately, but it happens in an era of recovery-focused care and renewed emphasis on involvement, which are partly key to the care and treatment plans. That then it's all the more worrying to see. Practice appears to have not moved on or shown much in the way of development. There's also a bigger problem, and that is that this lack of involvement is unethical and unjust. Imagine being in a situation where key decisions about your health and social care are being made based on assessments that you have not been consulted about, and that these very assessments may not be that robust or worth the paper that they're written on, or even that practitioners don't bother writing it down on paper, so there is no record or possibility of challenging or even engaging with the process. People in mental health care value relationships. It seems a kind of an odd thing to have to say because we're all intuitively aware of this. Workers value relationships, and people using services value those relationships too. We've heard it in all our studies. In forming meaningful relationships, we can be honest with others and we can have trust in what they say. And we can develop a sense of shared understanding about what is at stake and how best to deal with the issues. In our COCAP and our plan for recovery studies, we found many people saying all of this, but also we found service users telling us that they barely knew who their worker was, they could not confide in them, and they had no sense of sharing in decisions. Even in the most pressured of circumstances, making the time for establishing and maintaining relationships remains a significant priority in mental health care. How we talk about risk also has important implications for how we see people with mental health problems and also how they see themselves. Identity is an ongoing accomplishment that is worked up in interaction with others. If workers orient towards individuals as risky and take steps to limit or restrict their opportunities, then over time, it's likely that these same individuals will come to see themselves as people who are unsafe, who must be watched, and who must endure limits on their personal liberty. These ways of seeing oneself emphasize dependence rather than independence and fly in the face of the focus on recovery. If we want better risk assessment and management approaches, then we need to stop simply paying lip service to involvement. We need to build an evidence base of the best ways to engage people in decisions about safety and safety of others. And this needs to value their experience and involve them in decisions on the best ways to mitigate risk. The product of risk prediction has failed in mental health care. And now we must move to focus on practice and what can be known and involve the people that are central to the process and any solutions that we develop. This poster on this slide is from a hostel in the Netherlands, and it's indicating that we need to get our priorities right. We need to think about which priorities are culturally embedded and whether these are the correct ones. My suggestion is that prioritizing and including people in discussions about their care, including their safety and risk, is where we need to move towards. Thank you.
Michael, thank you very much. That was extremely helpful and informative, and not only just from what you've been saying, but also elements that were prompted, came up in the group chat as well there. It just strikes me that in terms of risk assessment, even now, how we do a lot of things to people, intentionally or unintentionally. I've been sitting here remembering my first world as a newly qualified nurse, when somebody would be assigned to watch the door. What exactly they were watching the door for, I'm not sure. It was something to do with people coming in and going out, but I think time would have been better spent therapeutically with people rather than on an intervention like that, which wasn't really one in the first place. Okay, for anybody who is curious, in the group chat, when there is a link, yes, you can click on it, because we've had suggestions about a number of modules and courses, and so yes, simply click the link in the group chat and that will just open up another window on your browser. So no harm in doing that at all. Again, adds to the experience. Thank you. Okay, and so I'm going to mute again, and we're going to hear from Professor Ben Hannigan in Cardiff University, and so over to Ben.
Hello everybody, this is going to be a shortened and updated version of a talk on mental health policy services and nursing in Wales that I've given in a number of places before. Let me grab my slides so that you can follow what I'm talking about. I'm going to begin with this very contemporary observation, which is that the COVID-19 crisis has, I think, shown the extent to which health policy is devolved across the 4 countries of the United Kingdom. So where the Westminster government was telling the population of England to stay alert, here in Wales, the Welsh government was asking the population to continue staying at home. I think I'm actually recording this podcast on the day that the First Minister, Mark Drakeford, has asked us to stay local, but the point is nonetheless well made. So how has the Welsh Government exercised its authority over the years since the Welsh Government came into being? Well, I think there has been a continued commitment in Wales to the idea that planning public services is a good thing. It's a good thing because it helps to eradicate inequalities. There's also in Wales been much less of a commitment to market mechanisms, certainly compared to England. Health boards, for example, both plan and provide healthcare, and that's very unlike the way in which the NHS in England, for example, is organised. And we also have some very particular words and phrases that have seeped into Welsh health policy language in recent years. We have the idea of prudent healthcare. We now have the quadruple aim, which is described in the Plan for Health and Social Care. And then we have some really important and distinct legislation, both of which, the two examples I'm giving here, future generations legislation and safe nurse staffing legislation, both of which have been hailed as globally important. Future generations legislation requires public bodies, including bodies in the NHS, health boards, for example, to plan not just for the present, but also for the future, and to think about longer term resilience. And safe nurse staffing legislation was hailed as novel internationally, and certainly at the time in which it became law, in 2016, unique here in the United Kingdom. How about mental health strategy in Wales? In what ways has that been distinct? Well, I think since devolution first happened, mental health policy and services have always been distinct in Wales. So at the time that England, for example, was pursuing very differentiated community mental health services, setting up things like assertive outreach teams and crisis resolution and home treatment teams and early intervention teams. Here in Wales, there was a commitment to the locality comprehensive community mental health team. I think it's also true to say that mental health and wellbeing have continued to be public service priorities in Wales. We see that in the many strategies that have been in existence over the last 2 decades or so, the most recent of which is Together for Mental Health, which is the Welsh Government's 10-year strategy for mental health. It's now towards the end of its existence, with the last third of its implementation period. And we have things like the Mental Health Wales measure. So when this was enacted around about a decade ago, it was really very distinct. Most mental health law internationally sets out the conditions under which people might be compelled to have treatment or might be compelled to come into hospital. The Mental Health Wales measure, on the other hand, talked about the positive rights of access that people might have to mental health services. It talked about people's rights to have their care planned and coordinated. How about mental health nursing in Wales? What do we know about our professional group? Well, we know that mental health nurses are the largest of the professional groups providing mental health care within the NHS in Wales. There are, according to the Stats Wales website, over 3,100 registered mental health nurses in employment in NHS Wales. At least that's the figure that was recorded in December 2019. We know that it's possible, it's continued to be possible in Wales to become a mental health nurse, become any type of nurse with bursary support in return for a commitment to work in Wales for 2 years post-qualification. And we also know that the framework for mental health nursing, with its multiple examples of good practice, its case studies, is a great example of a profession with confidence, looking not only to its present, but also to its future. But to what extent have these policy, these strategies, these ideas made a difference? How do we know that the measure Together for Mental Health, safe staffing, have made a difference to the lives of people working in and more particularly using mental health services? Well, there are perhaps a number of sources of evidence we might look to make a judgment on that. First are reports, inquiries or statutory reviews. These generally paint a positive picture of progress. So, for example, the Welsh Government, when it completed its statutory review of the Mental Health Wales measure, reported evidence of positive culture change. The National Assembly for Wales, now the Senedd, the Welsh Parliament, however, did note that there were demand pressures and that there were particular problems in providing young people's and children's mental health services. And interestingly, at least one expert giving evidence to the National Assembly before the measure was passed urged caution and said that the money to be used in creating the law might actually be better spent creating services directly. Progress is also reported in the context of reports on Together for Mental Health, a 10-year strategy, that access to primary mental health care is improving, stigma is reducing, that access to crisis care is improving. But a report commissioned by Plaid Cymru, the political party, last year, 2019, found that the lack of attention to routinely measuring outcomes of mental health services meant that it was really quite difficult to assess the impact of investment and reform. The other way in which we might come to some judgment on the extent to which policy and legislation are making a difference in Wales is by looking at research. So COCAP was a large cross-national, cross-England, cross-Wales study of care planning and care coordination that both Michael Coffey and I were involved in. Michael is also speaking as part of this mini conference. And we found, in truth, that it was very difficult to detect the impact of a legislative framework in Wales over a regulatory one in England in terms of how far people using mental health services were involved in care planning or how far care reflected orientations towards a recovery approach. When we interviewed them, care coordinators in Wales talked of being overburdened by administration. They talked of firefighting, they talked about lack of resources, they talked of collaboration not extending to matters around risk, which I know Michael is going to talk about during this mini conference too. In Plan for Recovery, which is a study that Michael Coffey led here in Wales, a study of people's use of social care mental health services, service users spoke of few opportunities to be involved in making decisions and a few opportunities to co-produce recovery. And Julia Terry's PhD also showed that many nurses in Wales are busy, they have too many tasks to perform, and people using mental health services find them insufficiently available to collaborate. So how might we conclude all of this? Well, first of all, I think it's fair to say that policymakers in Wales have consistently taken seriously the idea that planning at both national and local level is a good way to improve health and well-being. I think that the recent policy initiatives that we've seen from Welsh Government show that mental health, in the view of policymakers, is intimately connected to economic and social realities. I also think that legislation in Wales and policy has been distinct. It's certainly been novel. I'm thinking here about future generations legislation. I'm thinking about safe staffing legislation, which, along with the preservation of bursary, and nurses particularly, has shown commitment to nursing as a profession. But evidence from reports and inquiries and research shows that no matter how well intentioned policy and strategies are, they may in and of themselves lack the singular potency to bring about the kinds of changes to service provision and place-based practice that we might wish for. Perhaps we shouldn't be too surprised by that observation. Health systems are always complex systems, and there are invariably gaps between national aspiration and local face-to-face practice. Mental health nurses can certainly do more to influence, and the framework for mental health nursing in Wales is an opportunity to do more of that, I think. What the research suggests, I think, too, is that people who use mental health services value mental health nurses who are genuinely collaborative. And mental health service users value mental health nurses who make and maintain helpful relationships which are characterised by open decision making. I think that's an area where there may be a space for us to develop. Thank you very much. I'll stop there.
Again, thank you very much for your observations. I noticed a lot of activity in the group chats there, and I think perhaps if people are okay with this, it may be a good idea to pick some of them up at the end here. Okay, so really a lot of comment and helpful information this afternoon to help us think about a whole number of areas. And I'm going to say something maybe from a little different perspective now. And so we are heading over again to Cardiff, and I'll let my colleagues introduce themselves online. Thanks.
Hello, I'm Alicia Stringfellow, and I'm joined by my colleague Gemma Stacey Emile. Hello. We're both lecturers in mental health nursing at the School of Healthcare Sciences at Cardiff University. And we're here today to talk about a project we've been involved in the last 5 years, which is aimed at facilitating and improving engagement between inner city community groups and mental health services. Just to give you some background and context then, the project, which is called Community Gateway, is one of 5 flagship engagement projects within Cardiff University, and the focus is on Grangetown in Cardiff. And the core aim is to help make Grangetown an even better place by co-producing world-class research, teaching and volunteering opportunities which respond to local needs and ideas, and that ideas, resources and expertise flow in both directions and are mutually beneficial, not just to the residents of Grangetown, but also for us in the university. So the aims of Community Gateways are to work alongside the residents and organisations of Grangetown, responding to their concerns and suggestions, to develop a long-term community partnership with a variety of local organisations over a sustained period of time, and to develop partnership opportunities between Cardiff University and Grangetown to share our mutual and diverse expertise, passions and visions. The Community Gateway has 9 themes, and our part of the project, focusing on mental health and wellbeing, fits within the Healthy Grangetown theme. Why Grangetown then? This is just one inner city area of Cardiff, but following the 2011 census, we know that only 10.4% of households in Grangetown have English or Welsh as a main language. Coupled with that, there's limited involvement with statutory mental health services, despite high levels of unemployment and high levels of mental ill health. There was a willingness from Community Gateway key members to try to address the access issues and increase rates of engagement with mental health services, because we knew that there was a high number of statutory and non-statutory organisations locally that could help, and that we could tackle this lack of confidence that we found locally regarding clinicians and mental health services more generally. So Community Gateway partners identified a number of barriers encountered by local community groups that hinder their engagement with mental health service providers, and that co-producing a project aimed to ensure that empowerment and recovery are addressed by all those involved in the community group. We know that engaging with mental health services and having a mental health problem within the UK continues to attract public stigma and is a societal burden. So the project was set up around tackling some of that public stigma. So our work is very much supported by the literature, so that service users, family members and carers can start to trust mental health services in the hope that their engagement with those services will improve. Our aims then were to raise awareness of mental health and wellbeing issues within a diverse inner city area, and supporting residents to access the help that they needed, and also to provide a local facility where this support can be offered. For people to gain an understanding and awareness of the different mental health services, what they can expect from them, and how they may access these either for themselves or for others. And for mental health service providers to have a visible and approachable presence within the community. We asked the local residents what was unique about Grangetown, and they said it was a salad bowl, not a melting pot, and the place to find unusual things. It wasn't a clone high street. And they wanted a relationship with the university and not an affair. So something that was going to last a long time and was really sustainable over time. And that they had this relationship and not something that was dictated to them by mental health services, statutory organisations, or from us within the university. So I'm going to pass over to Gemma now, who's going to talk you through the plan and how we've got to where we are today.
Thanks, Alicia. I think it's just really important just to bear in mind a lot of kind of Alicia and I, what we really wanted to do was really to take this forward about that it's not about doing to somebody, it's a long-term relationship with residents of Grangetown as well. So the plan really was about engagement, and this slide just highlights really how it was really important for us to engage with residents, third sector organisations, mental health services, statutory, and how we could draw on local facilities to look at maybe offering services in a different way than what they are. So we had a look at the pavilion. We got some slides coming up around, just trying to use a different focal point to offer some of the mental health services within the locality. The participants were a range of third sector representatives within Grangetown, service users, family members, carers. And the key points were really about to improve knowledge and awareness of mental health conditions, services available, access and self-help. And another key theme really was to integrate into the wider community and to participate to bring about change, so that a whole range of service providers can work more cohesively in ensuring that everybody within the locality's mental health, mental well-being is looked after and offered. Okay, so those are the key points raised. Some of the observations that were highlighted were around partners recognised lack of engagement between different community members, so really diverse demographic within Grangetown, and some of the services that we've been offered, and that language barriers were really commonplace, and sometimes the translation around mental health terms and terminology and how they translated were really difficult as a barrier for people to access services that they may need. So over the past 5 years, we've had different, we've had annual events, and we've had themes over the year, which have been around, one of them about young people. We've had a session on dementia-friendly training. We've had the pavilion being used for women-only groups and for men-only groups and for carers. So our mental health and wellbeing events are spread throughout the year and also annually. So each year we celebrate the World Mental Health Day as well in October. So this is the pavilion as it was. There is a brand new pavilion in Grangetown, and I'm sure, if you're in Grangetown, is to let us know and perhaps go down and have a look at the new build, because it's quite amazing. We like to offer really, low-key events that is absolutely, kind of very informal and enables lots of interaction, talking and listening. Okay, so that's some pictures there. And overall, the outcomes from the project are that, the feedback we're getting is it has strengthened relationships between residents and key local mental health related services and the university. Feedback again is that we've been told really, what we're trying to do with local residents in the community is about the right information in the right place at the right time, and that they told us stuff we didn't know about mental health, which you're thinking about stigma, tackling stigma is really key, really important that we're getting this feedback as well, because that will also help us plan for the future and look at maybe different ways that community mental health and wellbeing events can be planned and who they're best placed for, really. So we've got our next event in October, which is the World Mental Health Day. So that's our presentation kind of for you. So I think Alicia's going to come back. What we have got is our contact details if you want us to expand or say anything else, or if you want to get in contact with us. Is there anything else, Alicia?
No, I don't think so. Thank you, Jen. Just to reiterate, really, that if you want to know anything more about the project, or if you'd love to get involved, then we really would like to hear from you. So don't be afraid to send us an email, and we can, get cracking on that as soon as we can. Thanks, then. Bye.
Bye.
Thanks, Alicia and Gemma. That was extremely helpful and very interesting to hear about your work in Grangetown. And as you zoomed into the Grange Pavilion, just looking at some of the different spaces and places there made me sort of catapulted back to where we started at the beginning of the afternoon with Ed's talk particularly. So we've come to the point now in terms of some panel discussion, lots of activity on the group chat, which has been extremely welcome. I'll ask Jamie and Martin to help me a little bit here, just in terms of finding people. I'm trying to find where Terry Davis and Joyce Stafford are on here, and it'll just take me a little while to locate people. There's Terry, fantastic. Okay, Terry, how have you found the conference this afternoon? Oops, Terry, you'll need to unmute. That's it. Okay, how's it been? Joy, how's it been for you?
I found the whole conference actually very interesting, purely from the academic side. But what I was wondering, how all of this actually affects the service user out there when they're actually under stress for one reason or another, and actually gaining access to services. Because what comes to me quite often is the length of time that they have to wait for maybe counselling and this sort of thing. And you do wonder, that length of time can be pivotal with regard to their treatment and ongoing progress.
I agree, Joy. It's certainly an issue that Hazel raised at the beginning. Terry, I'm sure there must be concerns you're aware of.
Yes. But certainly very interesting, and I really identified with Anne and her experiences, because my experience as well transverses from the early 70s right up to 220 with regard to experience in the mental health, and to look at all those changes and how far we've actually come from the large institution to community care as it is today.
There's certainly a lot of changes. I quite agree, Joy. Terry, did you want to come in? Terry, you're unmuted, but we can't hear you. Is there anything else to unplug there?
Can you hear me now? You can hear me? Yeah. Hello. Great, that's great. Yeah, there's so much to take in actually and to think about. It's brilliant to hear all different perspectives and so forth. Do you know, I think there's so many things I've spoken about over the last 20 years. It's the same things all the time. For me, it's all about relationship. It's all about people. It's about continuity of care. It's being with people for the long haul as well, that we can't, we'd all like to be able to fix things quickly, but the reality is when it comes to working with people who experience mental health issues, that the recovery, when you talk about recovery, can take weeks, months, and even years for some people. So it's being prepared to be with people for the long haul, to build that relationship. And I've said this over and over again, Julia, to your student nurses over the years, that it's all about the therapeutic relationship, about building that relationship, that rapport, there's been mention of trust, the need for trust between people. Partnership working, what's it all about? It's lovely to talk about it, but how does that translate into reality as well? In terms of supporting people, of people feeling valued as well. I think, you know, so much of that service users feel, because of what's happened to them in their lives and being in the system, don't feel very valued. It's trying to restore that sense of identity, self-esteem, self-confidence, that sense of value that people feel, really. And one of your contributors spoke about nurses being advocates. I think that's so true, you know, being able to speak up for those that have lost their voice at times as well. But it is, at the end of the day, it is all about people. You can have the best policies and plans and procedures in Wales, but if you don't, you know, connect with people, reach people, support people, hands-on care, really, then it's all pretty useless. It's all just, it's not going to make a real difference, really, is it? So it's people first, really, isn't it?
Yeah, absolutely. I think with relationships have come up a lot today, and as you say, in terms of how people feel, a lot about inequalities as well.
Yeah.
And Michael, that came up quite a bit in your talk about different things that people have said to you who you've interviewed over the years, you know, in terms of maybe a lack of involvement.
I think as well, you know, it's getting back to thinking about, I love talking about Nye Bevan, and he was the first to recognise, you know, that when it comes to health, you've got to deal with poverty as well, because as has been mentioned this afternoon, the poverty and levels of poor mental health are so intimately connected. So you've got to look at the bigger picture, not just look at the symptoms that people are experiencing, but, you know, question where they're coming from with backgrounds, like we've spoken about space and so forth, environment. So it's trying to always be aware of the bigger picture and how the bigger picture translates itself down into the individual level as well, isn't it? Because you can't divorce people from their space or from their environment, can you? It doesn't work. We're all inhabiting these spaces, as Ed's talked about, actually. So
yeah, I quite agree. I'm not sure, Ben or Michael, if you want to come in there.
I agree with what you've just said, Terry, and it was interesting. For the purposes of updating these slides and preparing this talk, I went back to look at Together for Mental Health. I mean, it's getting quite old now, so it was quite interesting to have a read of it from the beginning again. And it actually has quite a lot to say about, you know, material realities, you know, and the conditions in which people live, and how that's really intimately linked to people's mental health and well-being. And it's not, I didn't read it at all when I went back to it again as being a kind of a very narrow kind of clinical document. You know, it's much stronger on social and economic determinants of health and inequality, and how that's really important in mental health services.
It's interesting, isn't it? Because people forget Bevan wasn't just a health minister, he's also Minister of Housing. And Bevan made tremendous efforts to build local authority houses and good quality ones as well, because he recognized that people, you know, that the housing, the environment for people is really important as well in terms of helping them with good health as well.
Yeah, I completely agree.
Yeah, absolutely. Just for speakers to know, I have unmuted everybody now. So I don't know if anybody else wants to come in particularly. Just to
yeah. I was just going to add to that. So I think we can think about how that kind of operates over different scales as well. So as a nurse on a ward, there's things that you can do to change the space. You can change the place. It's in your. You can think about dimming lights at night. You can think about really pragmatic things like that. But you can also think about the big things and how you can affect change and how you can put pressure on things that are coming from above, and thinking about structural factors and that kind of thing. So I think there's a real interplay of scales here. Some of it can sometimes seem distant from kind of student nurses or kind of newly qualified nurses, and but there's things you can do, but there's also ways you can be an activist, or you can put pressure on in certain ways, and you can work for change. So it's really worth kind of thinking through all these different kind of scales, I think, and kind of working out where you can be the change maker in that.
Absolutely. So there's been quite a bit of activity in the group chat, lots of different things in terms of social isolation, stigma, discrimination have come up, doing things to people. And if anybody else wants to come in, please do feel free to comment.
So Julia, so maybe I might jump and say something at this point. I've found what people have been saying really interesting, and to pick up on Ed's point about what people might actually do as individuals, I think is an important thing to think about. My interest, of course, is in how people do or do not do shared decisions when they work with people with mental health problems. And I think one of the issues in risk and safety, which is reflected in some of the conversation, is how we tend to individualize quite a lot of the time in our assessments about the problem, when actually some of the problems are actually much wider. So it relates to stuff that Terry's been talking about, and Ben and Ed, because of course when people experience these assessments, and when they have problems with their mental health, it doesn't happen in isolation. So people aren't risk objects. We shouldn't be seeing people as being dangerous, as if it is embodied within who they are, but actually it's within the context in which they are. And I mean, going back many years when we first started examining risk, it was often said that context was the most important element of it, but it seems to have got missed somewhere along the line when we formalize and standardize different types of assessment processes. And what we've learned over the years, of course, is a lot of these processes actually don't do what they claim to do, so they're actually not that terribly helpful. So again, it's pulling back and seeing that big picture. It's about understanding people in their place and in the context in which they find themselves at the time at which they are experiencing this distress. And individual nurses may feel sometimes powerless, but actually they've got quite a significant role to play, and could really, they could really broaden the scope and involve people and give them an opportunity to make a contribution. And I think that would start to affect change in a lot of the work that happens in mental health care.
Yeah, I think so. Okay, so as is traditional with most events, we'll have a couple of short polls here. So just an opportunity for you to tell us about your overall conference experience today. Only literally just a few questions. I am absolutely indebted to all of you for taking part. Thank you very much indeed. And my particular thanks to all our presenters, to Hazel for giving us the opening welcome, and particularly to Jamie Wheeler and Martin Nosek from Swansea University, who I couldn't have done any of this without you. So thank you very much indeed. We've got quite a lot of people replying here in terms of conference experience. There's only one more question, I think, after this. I have been asked by people about making the link available. So the recording of this, which has gone to the cloud, will be, a link will be sent to everybody. So it will come to you even though you've been here this afternoon. Again, just in terms of some useful topics that people may wish to follow up at some point. I don't think we're going to get any more voters here. Okay, so I shall close that particular polling. All right, that's look, so the majority is would highly recommend events like this. And in terms of could have been better, okay, really happy to have some suggestions for improvement from you, please. This was rather a homemade flavour. And as I said at the beginning, this very much was spiralled from the South Wales Mental Health Journal Group, which has been around for 20 years now, started by Ian Beach, Michael Coffey and Ben Hannigan. And particularly whether we're in lockdown or not, it's really useful to see different ways that we can get together. So the last two questions, I promise now, available for you to click one option only. Using this online method for participatory learning has, and then what you liked most. for a few more results to come in. And equally happy to have suggestions from anybody in our audience and organisations about things that we can do online in terms of talking about mental health. There's lots that we're starting to see available in a range of different media. Okay, that's replies from quite a lot of people now. And just thank you very much for everyone for your thanks. Okay, right. It's great when you can see the numbers adding up. Right. Okay, so I think we're about there. So I'm going to end the polling. So we've got 80% of people felt this worked well, 2 not so well, okay, and 6, well, at least it didn't leave a lot to be desired. I'm forever grateful for that. And in terms of what you liked, most people liked the presentations and the topics. And it will be also helpful to have other suggestions because people might want some kind of a theme for another time. Oh, would you like to see for future events? No, I missed that question entirely. More learning events like this. Okay, and people like things they can dip in and out of and have this more regularly. Okay, so I think there's some oh, I didn't share the results, there we are. So that's nice for people to be able to see too. Okay, right. Well, I'm going to wish you all a very good rest of the day, and certainly in terms of topping up our water and some stretching, and perhaps not working too late today either. So thank you very much everybody for all your contributions and help today, much appreciated, and look forward to seeing you another time and catching up soon. Thanks very much everybody. Bye-bye.
Bye.
Bye.
Bye. Bye.